Thank you, ma'am, for the very kind introduction. A very good evening to all of you. At the outset, I'd like to thank AIOS for this opportunity. So today I'll be describing a technique for cross-linking in thin corneas. I have no financial interest. Now, as we're all aware, corneal cross-linking is the only treatment modality which helps to halt the progression of ectasia, both iatrogenic or idiopathic. The standard Dresden protocol entails a minimal stromal thickness of 400 microns, so the procedure can be carried out safely without endothelial damage. Unfortunately, a number of the patients, especially in developing countries such as ours, present at a later stage, wherein their corneas might be thinner than that what is considered safe for the traditional cross-linking process. Thus, over the years, a number of new treatment modalities have evolved for these thin corneas. Hypoosmolar riboflavin entails the installation of riboflavin with NaCl as against dextran or HPMC. The aim is to artificially swell up the cornea intraoperatively in order to increase the stromal thickness. However, one of the limitations of doing this is that the concentration of collagen in the hydrated stroma is actually lower than the original physiological stage. Also, the collagen fibrils are now further apart than they were in the original state, which makes the cross-linking less effective. Another technique that was described was the transepithelial cross-linking, wherein the epithelium is left intact in order to add another 50 to 55 microns to the corneal thickness. This can either be done with riboflavin along with other compounds such as BAC or proparacaine, or by the use of iontophoresis. In this, an annular ring is applied around the cornea to generate a thin current. Since riboflavin is a charged molecule, it allows the movement of the riboflavin particles across an intact epithelium. However, the efficacy of these transepithelial procedures are controversial. One is because of the limited penetration of riboflavin through a relatively intact epithelium. However, more importantly, the concentration of oxygen in the corneal stroma is now reduced. This is because we all know that the epithelium takes oxygen at a rate which is faster and far greater, about 20 times or so as compared to the corneal stroma. So when the epithelium is left intact, the amount of oxygen diffusing into the stroma is reduced, thereby reducing the efficacy of the aerobic CXL process. Contact lens assisted CXL was another technique which was described, wherein a 100 micron contact lens was used intraoperatively to augment the stromal thickness. However, the absorptive and the biochemical properties of the contact lens are obviously vastly different from the underlying corneal stroma. So we have described a technique of trailer stromal expansion, wherein a lenticule from a patient undergoing SMILE is used for intraoperative stromal augmentation in these thin corneas. Now, the principle is simple. When you obtain a lenticule from a patient undergoing SMILE, it is thicker in the center and thinner in the periphery. So the placement will be such that the center of the lenticule or the thickest area should overlie the apex or the thinnest area of the cone. Now, this is a small video of the procedure. We begin with the epithelial debridement. This is done under topical anesthesia. The lenticule, as I had alluded to earlier, is obtained from patients undergoing SMILE for myopic correction. These patients undergo serology testing for both HIV and hepatitis virus. Now, the center of the lenticule, which is the thickest area, is placed over the thinnest area of the cone, and a final thickness of more than 400 microns is then checked using an intraoperative pachymetry. The cross-linking can be done either with a conventional or an accelerated approach, and one can see that the lenticule is firmly adherent to the underlying stroma throughout the procedure, unlike a contact lens. The stroma is then washed and a banded contact lens is placed. So these were the initial results in our first cohort of 7 eyes, which was published in 2015. The lowest epi of stromal thickness was 321 microns. These patients now have a mean follow-up of 4.2 years, and all eyes have shown disease stability. In terms of safety, there was no significant endothelial cell loss in any of the eyes. The incidence of stromal haze and the resolution was similar as compared to the conventional approach. A clear demarcation line was seen in these eyes, ranging from around 210 to 240 microns. So, what would be the advantages of our technique over the earlier described techniques? This is a physiological increase in the thickness as against the contact lens, wherein the properties of the contact lens are different from the underlying stroma. One of the most important advantages is that one can tailor the expansion. So, unlike just a 50 micron or a 100 micron increase with the epithelium or the contact lens, the increase here would depend on the thickness of the lenticule that you have procured, which is based on the refractive error that one is correcting. Another important factor is that the augmentation is not global, it is focal, and there is a greater augmentation over the area of the cone where the thickness needs to be augmented. Also, the firm adherence of the lenticule to the underlying stroma, unlike the contact lens, does not allow riboflavin to pool or form cold spots. So, after the safety and the efficacy of this technique was established, we went on to do this technique along with the use of intracorneal ring segment implantation in 3 eyes. So, these eyes were either cases of postclassic ectasia or advanced keratoconus, wherein the keratometry was too high to give a good best spectacle corrected visual acuity with cross-linking alone. Moreover, it was a central cone wherein the center or the thinnest pachymetry was less than 400 microns, but we had enough thickness to implant intracorneal ring segments in the paracentral cornea. So you can see that there was a significant improvement in the maximum keratometry in all 3 eyes with an associated improvement in the corrected spectacle visual acuity as well. So this is how the procedure went. We used the Visumax femtosecond laser system to create the channels for the intracorneal ring segment implantation. Using a blunt spatula, the incisions were opened and the intracorneal ring segments were placed as per the nomogram by the company. Again, this was an epi-off procedure. Following the epithelial debridement, the lenticule was placed and the remaining procedure was similar to as I have already discussed earlier. Now, this is one of the eyes you can see with a 3-year follow-up, wherein there is a gross improvement in the anterior corneal aberrations or the anterior corneal surface. The keratometry steepening has drastically reduced with an improvement in the IS asymmetry. You can see preoperatively that the pachymetry is enough for the intracorneal ring segment placement in the paracentral zone. However, the thinnest pachy was 380 microns. So I just like to conclude that what we've described is a trailered stromal expansion in thin corneas. It is a safe and an effective technique with a follow-up of 5 years. And it also reduces the need for more invasive procedures like keratoplasty, wherein you don't have other options because the cornea is very thin and is highly aberrated. Thank you.
Thank you, Gitansha. I think that was a very nice presentation.